Here is a detailed and comprehensive explanation of physostigmine. Suitable for medical, nursing, or pharmacology study purposes. 1. Basic drug information. Generic name, physostigmine. Drug class, reversible acetylcholinesterase inhibitor, parasympathomimetic agent. Chemical name, 3AS8AR. 1.388-trimethyl-7,8-A-dihydro-3H-pyrrolo 2,3-B-indol 5-ol methylcarbamate salicylate. Brand name, Antilirium. Available forms. Injectable solution for IV or IM administration. Common concentration, 1 milligrams per milliliter. Physostigmine salicylate, supplied in ampules or vials. Number 2 definition, physostigmine is a reversible cholinesterase inhibitor derived from the calabar bean, Physostigma venenosum. It increases the level of acetylcholine, ACH, in synaptic clefts by inhibiting the enzyme acetylcholinesterase. It is primarily used as an antidote for anticholinergic, atropine-like toxicity that affects both the central and peripheral nervous systems. Number 3. Mechanism of action. Normal physiology, acetylcholine is a neurotransmitter that mediates communication at both nicotinic and muscarinic receptors. After release, it is rapidly degraded by acetylcholinesterase, ACHE. Drug effect, physostigmine reversibly inhibits ACHE, preventing breakdown of ACH. Result, increased ACH concentration at synapses, enhanced cholinergic transmission at muscarinic receptors, heart, smooth muscle, glands, nicotinic receptors, neuromuscular junctions, CNS receptors, improves alertness, cognition, and reverses delirium and anticholinergic toxicity. Because physostigmine is a tertiary amine, it crosses the blood-brain barrier, allowing it to treat central symptoms like confusion, hallucinations, and agitation, unlike neostigmine or pyridostigmine. 4. Pharmacokinetics, property, description, absorption, rapid after IV or IM injection, distribution widely distributed, including CNS, lipid-soluble, protein binding, 85%, metabolism, rapidly hydrolyzed by plasma esterases and hepatic metabolism, onset of action 3-8 minutes IV, duration of action 45 to 90 minutes, half-life approximately 15 to 40 minutes, excretion renal as metabolites. Number 5. Uses. Primary approved use, reversal of anticholinergic toxicity, e.g. from atropine, scopolamine, tricyclic antidepressants, phenothiazines, or antihistamines. Secondary off-label uses, diagnostic aid for myasthenia gravis, historical, now replaced by edrophonium, rarely used for reversal of neuromuscular blockade. Experimental use in Alzheimer's disease, superseded by donepezil and rivastigmine. 6. Indications. Confirmed or suspected anticholinergic syndrome characterized by hyperthermia, flushed skin, red as a beet, dry mucous membranes, dry as a bone, mydriasis, blind as a bat, delirium, mad as a hatter, urinary retention, full as a flask. Reversal of CNS and peripheral symptoms due to atropine, scopolamine, diphenhydramine, tricyclic antidepressants, or antipsychotics. Number 7. Contraindications. Physostigmine should not be used in patients with 1. Asthma or COPD may cause bronchoconstriction. 2. Cardiovascular disease, bradycardia, conduction abnormalities, or heart block. 3. Mechanical obstruction of gastrointestinal or urinary tract. 4. Epilepsy or seizure disorder. 5. Tricyclic antidepressant TCA overdose increases risk of asystole and seizures. 6. Hypersensitivity to physostigmine or related compounds. Number 8. Precautions before taking. Administer only under medical supervision with resuscitation equipment available. Continuous cardiac and respiratory monitoring is required. Atropine sulfate, antidote for cholinergic crisis, should be immediately available. Use cautiously in pregnancy. Category C, risk cannot be ruled out. Lactation, unknown if excreted in breast milk. Patients with diabetes, peptic ulcer disease, or Parkinson's disease. Number 9, how to use. Route intravenous IV preferred. Intramuscular IM if IV not possible. Administration guidelines, administer slowly over 5 minutes. Avoid rapid IV push, can cause bradycardia, seizures, or asystole. Observe vital signs and ECG continuously. Repeat doses only if symptoms return or persist. Number 10, dosing information. Adults, initial dose, 0.5 to 2 milligrams IV slowly over 5 minutes. Repeat dose, every 10 to 15 minutes as needed, maximum up to 4 milligrams per hour. If no response after 2 milligrams, reconsider diagnosis. Children, dose 0.2 milligrams per kilogram IV slowly, maximum single dose 0.5 milligrams. Repeat every 5 to 10 minutes if needed under monitoring. IM administration. Same doses can be used IM if IV access unavailable, slower onset. Number 11. Misdose overdose. Misdose, not applicable, used only in emergency or monitored clinical settings. Overdose symptoms. Cholinergic crisis, excess ACH, bradycardia, hypotension, sweating, salivation, diarrhea, vomiting, meiosis, muscle weakness, respiratory depression, seizures. Treatment. Stop physostigmine immediately. Administer atropine sulfate 0.5 to 1 gram IV to counteract effects. Provide supportive measures, airway management, oxygen, IV fluids. Number 12. When to stop or avoid taking. Stop or avoid further dosing if severe bradycardia or asystole occurs, seizures or severe bronchospasm develop, patient shows paradoxical worsening of delirium or agitation, no improvement after 2 doses, likely not anticholinergic toxicity. Number 13. Side effects. Common mild, nausea, vomiting, diarrhea, increased salivation, sweating, urination, dizziness, headache, meiosis, pupil constriction. Moderate to severe, bradycardia, hypotension, muscle twitching or weakness, seizures, respiratory depression, bronchospasm, asystole, rare but life-threatening. Allergic reactions, rash, itching, swelling, rare. Number 14. Vital safety information. Physostigmine is a high-risk emergency drug. Administer only in hospital or ICU. Always confirm anticholinergic toxicity before use. Atropine must be readily available as an antidote. Do not mix physostigmine in alkaline solutions unstable. ECG and vital monitoring are mandatory. Readminister only if symptoms reappear, short half-life. Number 15. Drug interactions, drug class effect, interaction, anticholinergic drugs, atropine, scopolamine, antihistamines, decreased effectiveness of anticholinergics. Other cholinergic agents, neostigmine, donepezil, pilocarpine, additive cholinergic effects, toxicity, beta blockers, propranolol, metoprolol, increased risk of severe bradycardia, TCA antidepressants, amitriptyline, nortriptyline, contraindicated, may cause cardiac arrest or asystole. Corticosteroids may reduce effectiveness. Neuromuscular blockers, succinylcholine, prolonged depolarizing block. Anesthetics, halothane, isoflurane, increased risk of arrhythmias. Summary table, category, key points. Drug class, reversible acetylcholinesterase inhibitor, main use, antidote for anticholinergic toxicity. CNS penetration, yes, crosses BBB. Onset duration, 3-8 min, 45 to 90 min. Antidote for overdose, atropine sulfate. Major contraindication, TCA overdose. Monitor ECG, BPH-RRR. Serious effects, bradycardia, seizures, asystole. Thank you. Have a nice day.